Do you want me to share the PowerPoint, Dr. Martin?
Yeah, if you want. If not, I'm sure I can pull it up off my email.
I can pull it.
Okay, thank you. All right.
Do you see it?
Yes, ma'am. So
Okay,
thank
perfect.
you all. Again, we're going to look at some of the labs that we can use to, monitor alcohol use in clinical settings. Have no disclosures objective wise. We're going to kind of lead with just talking about, why we use drug and alcohol testing in clinical practice and kind of the limitations. And it's important to remember that these tests do not completely eliminate the need for clinical decision-making or clinical interpretations. They are just tools that go into the overall clinical making decision process. And then we're going to look at some of the serum laboratory testing that we can utilize for alcohol monitoring, as well as some of the urine testing that's available. So next slide, please. As I mentioned before, labs are, I would say they're essential in treating substance use disorder when we're looking for lab toxicology testing. But again, they don't replace all clinical decision making, and labs have their deficiencies. Many of them have false positives, and they are definitely not perfect in collection always, and collecting certain leaving things out on room temperature too much, collecting things incorrectly can also alter labs. And we'll look at some of that today in our alcohol testing. But when we are using drug testing, we also need to have as clinicians, a non-punitive process in mind. So the reason we utilize drug testing is not to punish patients, but to help guide and direct us in our clinical decision-making and their treatment planning. And so we can definitely utilize drug tests to help assist in diagnosing individuals, assist in creating an initial treatment plan, and then modifying that treatment plan when necessary, when people are not doing well. It helps us monitor patients' abstinence from substances. So are they using things or not using things? And in many cases, particularly with medication-assisted treatment, it can assist us in monitoring adherence to that treatment. So looking for are they using their buprenorphine? Are they using their methadone effectively if we're looking at opioid use disorder? Next slide, please. But today we're going to talk about alcohol. We'll talk about opioids later in the year. So I'll start with some of the serum testing or blood testing that is available for helping indicate or detect alcohol use. The first three things I'm going to talk about are kind of the older school way in which clinicians would help identify some possible alcohol use. We'll look at GGT and MCV and LF, and then AST and AST, ALT and AST, sorry. Those are less specific to alcohol use disorder. And so generally, if we only have these three biomarkers available, we want more than, you want at least a couple of them to be positive before you start confronting someone on alcohol use, because they're just not specific only to alcohol use. The GGT is the gamma glutamyl transferase. It's done by blood draw, and it's found to be increased in about 75% of individuals who have alcohol use disorder, who are heavy alcohol use. It can also be elevated from other things as well. So as I mentioned, not specific. So fatty liver diseases, obstructive liver disease, so pretty much any kind of liver disease where there's liver death or liver necrosis of cells can result in elevation of GGT. And then some anti-epileptic medications can as well. We know that if GGT is elevated from alcohol use, if they stop drinking for 2 weeks, the number should reduce to about half of what it was when they were actively drinking. And within 6 to 8 weeks, GGT tends to return to normal once they cease drinking. And of course, that's going to be with the caveat that they don't have cirrhosis or fatty liver disease or other liver diseases that may keep that elevated despite the cessation of alcohol use. The MCV is the mean corpuscular volume, and this is looking at your red blood cells, and it's looking at the volume of your red blood cells, and even really less specific to alcohol use, MCV. But your MCV will increase in most individuals with heavy alcohol use. And so it's something you could utilize as a tag along. So if their GGT is elevated and their MCV is elevated, maybe we have someone who's drinking alcohol. It also can be increased with people with vitamin deficiencies like B12 deficiency, as well as thyroid diseases. Next slide, please. And then the third of the older labs that we used prior to the newer technology or the newer laboratory results was the AST-ALT ratio. These are also functions. These are also enzymes that are released like GGT when there's liver damage or kind of liver, when there's issues with the liver. And so with other liver diseases, it could be elevated even if that's independent of alcohol use. But it also will often be elevated in heavy alcohol use, particularly in those who have been chronically using alcohol. And the ratio of the AST to ALT is usually greater than 2 to 1 with alcohol use. And you don't always see that with other liver diseases like hepatitis. So it's something you can utilize diagnostically. And again, those first 3 tests are better predictive if there's 2 or more of those positive at the same time. And so those are our traditional medicine, prior to the last 20-year options that we had to test. But we do have a lot of newer labs that are available now. One of those is the carbohydrate deficient transferrin lab, or the easy way to say it is CDT. This is also a serum lab, and it helps detect individuals who are drinking daily and heavier amounts. And so generally in a normal size, non-overweight individual, you're going to have elevation of a CDT when that individual is drinking more than 3 drinks or 60 to 80 grams of alcohol daily. And that they need to be doing that for at least a week. So it's not as good at detecting binge drinking. This is going to be more of a daily drinking detection. If those individuals are heavily obese or overweight, it can take up to 5 drinks per day for a week to elevate the CDT. But the CDT is very specific for alcohol use. And so that gives you some specificity with that. It's also can be increased with some liver diseases. So it's not completely specific only for alcohol use, but more so than the previous 3 things we talked about. Next slide, please. An even newer option that's available is the phosphatidylethanol, or PEth result. So PEth testing is very expensive. So is CDT. These newer tests are much more expensive than our old, just looking at GGTs and AST, ALTs and MCVs. And usually when you see PEth used, it's usually in criminal justice systems, so they utilize it. It's a little bit more convenient in that you can use a finger stick to get PEth measurements versus a full venous draw like you have to with the other tests. And so you see it again utilized mostly with drug courts and legal system. It's very specific to alcohol. As from the literature I was reading, there's really not anything else that elevates it. It's 99% specific, actually. And so if your PEth is positive and you are utilizing this exam, you can be fairly confident, highly confident that these individuals are drinking alcohol. And it has a half-life of about 4 days of detection. And so usually within the first week after getting off of that, the detection sensitivity will go down, but it can be detected for 1 to 2 weeks in some individuals who are heavy drinking. Of course, there's the blood alcohol level, and the blood alcohol level does not detect chronic drinking. It's really detecting just more immediate use of alcohol, because alcohol elimination, as we talked about a few weeks ago, occurs for most people within 6 to 8 hours after their last use, at least elimination from the serum and the blood alcohol levels. So blood alcohol level is still considered the gold standard for intoxication or immediate need to evaluate an alcohol level. And so this is done by blood draw as well. And it measures the amount of nicotinamide adenine dinucleotide plus hydrogen, or NADH, that's formed during the oxidation process of alcohol. There are some things that can falsely elevate BAL levels, including starvation, any kind of ketoacidosis that occurs in the body, either through diabetes or starvation. And it's the main thing used to set standards. BALs and then breathalyzers are the two things utilized by law enforcement to set standards for what they consider safe or driving limits. And I say safer, and we'll talk about that next week, because even small amounts, even 30 milligrams per deciliter of alcohol, can start to cause some impairment for individuals. But most states use between 80 and 100 milligrams per deciliter safe of a BAL as a safe driving limit. Oklahoma uses 80. Next slide, please. I thought we were talking about next week, but we're talking about this week. I apologize. Alcohol intoxication. Here's a list of alcohol intoxication as it correlates with blood alcohol levels in individuals who are not consistent active drinkers. So in many of your patients with alcohol use disorders who have been drinking regularly for weeks, their blood alcohol and they've had time to build tolerance, their blood alcohol level may not be correspondent to the clinical symptoms they're presenting. And so basically what that means is, as you get used to drinking, you can have a higher blood alcohol level and not have the symptoms that most people would have during that time. And so, for instance, I've had people come in, patients I've seen who are in the 200 to 300 range blood alcohol level, but are sitting there talking to you and able to walk because the tolerance has built in their system. But if you're a non-tolerant individual, this is generally what you're looking for in terms of performance impairments from intoxication. So as I mentioned before, even in the 20-30 range, you can start to have slowed motor performance and decreasing ability. Once you get to that 80 range, you can have significant motor and cognitive problems, which is why the states usually put driving limits around there. In the 80 to 200 milligrams per deciliter, you're having in coordination, making more likely to make judgment errors. Your mood's more likely to be labile or fluctuating, and can lead to significant deterioration in your cognition. And then the 200 to 300 milligram per deciliter range, people are really drunk at this point, where you get that slurred speech, that nystagmus. They're usually walking, stumbling around, and this range they can start to have what we call those alcoholic blackouts, which are amnestic episodes of that people have when they're drinking higher levels of alcohol. And once you get to 300, more than 300, death is possible by alcohol intoxication. Next slide, please. We do now have some urine testing options for alcohol use versus just the serum testing. And the benefit of urine testing is that you can do these in outpatient clinical settings, even if you don't have a lab attached to you. So you can order these, you can have them built into your urine testing cups if you would like to do that. Definitely the more stuff that you add that's not as typical of the standard Department of Transportation screens, it definitely makes things more expensive, but you definitely can test for alcohol in a drug screen, in a urine drug screen now. The one that is primarily used is something called ETG, or ethanol glucuronide, which is a metabolic product of the breakdown of alcohol, and that's going to be detected in the urine, usually within the first 22 to 31 hours after drinking. So you can't use it for immediate testing. So if it's before 22 hours from the drink, you're going to probably want to get a blood alcohol level if you're needing an urgent level that quicker. But it will detect alcohol for a fairly long period of time, alcohol use within a fairly long time, 5 to 6 days. As with other labs, you shouldn't use it solely. You need to correlate it as a indication of that they absolutely drank alcohol or that they have an alcohol problem. You should correlate that with other clinical data. And two main reasons, well, the main reason has to do with the sample itself. And so if you do not process the sample quickly enough and it sets at room temperature, it starts to build bacteria in the urine that will falsely test positive for the ETG. And so if you're not going to be able to immediately dip the urine after collecting it, they recommend that you put it in the refrigerator, and the refrigerator will slow the bacterial buildup that cause false positive ETGs. There is something called the ethyl sulfate, or ETS, also a urine test that's similar to the ETG in its detection periods, but it does not cause, even if you leave the urine out for longer periods of time, it won't test positive just because bacteria are present. Another thing with ETG is that if you are a diabetic and you have urinary tract infections, they tend to have falsely positive ETGs as well. You don't see that with ETS. ETS is just not used as much because it's a newer test and it's more expensive. So ETS has some benefits, but it's giving you the same thing. So if you are taking care of your specimens and your patient's not a diabetic with a urinary tract infection, the ETG is going to be fairly effective in detecting alcohol. Next slide, please. And then, of course, last but not least is the breathalyzer, which is commonly used by the Department of Transportation and law enforcement to detect immediate intoxication. So it's kind of like the BAL in that it's used for intoxication levels, not use in the past. It's used a lot more than BAL because it's just more convenient. You have a device that can be used in the field to detect a level of alcohol. It takes about 15 minutes to get really accurate readings from the breathalyzer, 15 minutes from the drink or from the last drink. And it will underestimate the blood levels by about 10%. So it's not quite as good at giving you the exact values of blood alcohol level. And it's going to be read in grams per 210 liters. And what you usually see is you'll talk of people blowing a 0.08 or something like that. So you'll hear terminology like that with the breathalyzer when law enforcement's using it. I think that's the last slide, but we'll double check. So that just kind of goes over some of the the intoxication measurements that we can utilize, as well as blood levels. Serum levels, we're looking at more chronic use or heavy use, and the same with urine. So any thoughts, questions, comments?